Okay, great. Thanks, Adam. Let's go ahead and move to our second speaker. Let me introduce Sara Canavati from the Mahidol Oxford Tropical Research Unit, Moru in Bangkok. And the title is Targeting High-Risk Groups Experience from the Greater Mekong Subregion.
Is there a pointer? No. Oh, people use this. Okay, thank you. Thank you so much for the introduction, and thank you so much for the invitation. I feel really honored to be able to speak about our Cambodian experience. And I'm so glad to see my Cambodian colleagues in the audience. Thank you so much for coming. And to be sincere, I'll be presenting on behalf of many people. So I don't want to take credit for everything that's on the screen. It's been a collaborative effort. And so my topic is P plus T3, prevention, test, treat, track among populations at higher risk of malaria in Cambodia. This is a case study of the Cambodian example. So just a bit of background. As you all know, artemisinin resistance was fully documented in 2009, and there were a series of interventions amongst populations at higher risk of malaria as a response to this threat of artemisinin resistance. Today, as we speak, falciparum malaria is in danger of becoming untreatable in Western Cambodia, since there is already documented resistance not only to artemisinin but also to ACTs. And I'm running a clinical trial, and it's also it's an issue. Cambodia has set itself a pre-elimination goal by 2015 and elimination of all forms of malaria by 2025. And I'm so glad to have the National Malaria Control Program Director in the audience. So eliminating falciparum malaria will eliminate resistance. That has been also documented by Kara and Rolly and colleagues. On World Malaria Day 2012, WHO launched the T3. So I'm just adding a P for prevention. And there is also a WHO framework as an emergency response to artemisinin resistance that also has a huge emphasis on mobile migrant populations. So the study took place in 6 provinces of Western Cambodia, labeled as tiers 1 and 2. The methods are pretty complex. I won't go into it for the sake of time because I want to go more into the programmatic implications, and thanks Alan for introducing the methods already. So I just want to, I have been asked to explain from a programmatic point of view how would this translate into the field. But there were, so this is what the presentation looks like. We have a target population of populations at higher risk of malaria. We have 4 initiatives: prevention, test, treat, and track. We have aims, and we have interventions. So this is what what I'm going to be talking about. So a lot of my slides have these two, and I won't go into detail, but I didn't want to take them out just to emphasize the importance of evaluation of every single program that we implement among mobile migrant populations. So we always have to ask ourselves what worked and what did not work. Because actually most of the interventions that we have implemented in Cambodia work. But doing the evaluations, we have noticed some things that don't work. And just being able to improve those things, we are able to have more access and outreach. And of course, measure the effectiveness of the interventions. So as prevention, so the aim is improve knowledge and skills, right? So we've done mass media, mobile broadcasting units, listener viewer clubs, and mass media has had a limited effect because it doesn't really reach where these populations are due to the lack of access to media or electricity. So it worked because some of these people reported that their knowledge had improved their behavior. However, there was very limited access. BCC. So BCC has been a main component of this strategy. And in the study, those who received health education by the mobile malaria worker were 2 times more likely to sleep under an ITN. And also those who were able to recall 2 key diagnosis and treatment messages, and those who were able to discuss about malaria. The village malaria workers and the mobile malaria workers and now the plantation malaria workers are fully devoted to working on malaria in Cambodia. So what worked is that they are close to the communities. They are very, very close to the communities. But what it did not work, and we are working on it, is access, and also hard to follow up. So prevention, we did a positive deviance exercise. However, the baseline and end line, because this is cross-sectional implementation, is very difficult to measure behavior, since and by the end line your population is different, because we're talking about populations that usually move around. So another intervention that has been taken out by different NGOs such as URC and FHI 360 are the taxi driver program. And this taxi scheme is meant to target MMPs on the way. So it worked really well, because when we interviewed people, they were aware of malaria, and it worked really well as a tool of informing people. However, the taxi drivers had to be a bit more active, a bit more proactive in outreaching. Prevention, increasing access to prevention measures. So the ITN lending scheme, or now LLIN, it was in place because the mobile malaria populations working in plantations and farms do not have access to the free distribution campaigns. So basically, this is a mechanism that is being placed in place and is now being adopted by the national program and is covering most of the country. And this is a way to give access to migrants while they are in the farm to treated nets. So this is a typical village malaria worker equipped with RDTs, the first line treatment. So in terms of test and treat, the ones who play the highest role in Cambodia are the village malaria workers. And they are very, very active in their communities. And they are also, they also know who's new in the village, who's coming back from the forest. So because they're part of the community, right? So they are a farmer. I mean, they are just part of the village. So these provide early diagnosis and treatment services to hard to reach populations. Actually, this project has been going on for a while. Since 2003 was piloted. It started in 2004. However, in 2009, due to containment efforts, it was upscaled significantly. And now 2011, it started with the mobile malaria worker, targeting mobile populations, and now lately, just recently, 13 with the plantation malaria workers. So in terms of track, that's where I wanted to spend most of my time. But so the most important thing is to know the population that we are trying to target, because the Cambodian experience, it might not be the experience of other countries. So it's very important to know your population, to know what are the risk factors, to know who they are. And we've used respondent-driven sampling. We used it in 2009. We used it in 2011, 2012. There have been quite a few surveys, and they've been very useful. I won't go into the findings because we don't have the time, but they've been very useful in identifying who these populations are, what are their risk factors, and also to identify where is their malaria prevalence or malaria status. So it's and also whether there is any correlation between the interventions at specific place and where they are coming from. So we've been able to find out a lot about these people through RDS studies. There is a poster tomorrow that Chandra Rang is presented that, and he's here in the audience. So you can go to that. Is actually there is nothing that did not work with that one, just that is a bit costly if you want to implement it. And there's been plantation mapping and also conducted by PSI. Mapping the populations is very important, where they are, because we need to know what they are doing, but also where they are located. And this is just an example of how PSI has mapped the rubber plantations, and they also mapped the rubber plantations and the construction sites. So it gives you an idea of where these people are. I mean, very useful. Also, they were able to identify what types of workers were employed and where, and what was the length of stay. So, and also the village malaria workers are a key component of the track strategy because they are part of the communities, but this is done through passive case detection. So if you can see here, when the increase of percentage of villages with a village malaria worker, there was actually, of course, increasing reporting, both from the health information system, and this is combined with the health information system and the VMW database. We did this analysis as secondary data. So far, the VMWs have detected close to 400,000 cases. So the village malaria workers are pretty strong component of the track. In terms of cross-border screening, we did pilot project in 3 different borders. It was a border with Laos, border with Vietnam, and a border with Thailand. And we enrolled over 3,000 cross borders. So we had a 5.4% were parasite positive, with the highest proportion at the Laos border. And when we did the PCR, there was actually 60.2% of the falciparum cases had K13 mutations from all participants at the Laos border point, which it doesn't only indicate that malaria is spreading in is occurring in different sites independently, but this also shows the spread of drug-resistant malaria, or malaria itself. So what I wanted to go in, there is a poster actually on this in poster 337, but that was yesterday, but you can look up the abstract. And it's important to see what are the risk factors of these people. And actually, they were males, they had a fever, they were forest goers, they had low knowledge on malaria prevention, and they had a previous malaria episode. So in terms of active screening and treatment, we conducted this study to see where the asymptomatic reservoirs were located in Pailin province, where is the epicenter of drug-resistant malaria. And it was a very successful study. You can look up the publication at the Malaria Journal. And over the study, we were able to screen close to 2,000 non-index cases. So, and the chances of finding a positive case in an index household was 2.1 by microscopy and was around 4%, 4 times more likely by PCR, RT-PCR. So I'm coming to the end. After all these studies, and then we also did I didn't go through the methods, but we did a lot of consultative meetings and workshops. We reviewed a lot of the gray literature, and then we also reviewed a lot of the reports from studies from different implementing NGOs in Cambodia. We were able to come up with a risk of malaria framework. So basically it has three variables. Well, it's actually 3 indexes, and these indexes have tons of variables that I'm not able to go in depth. But just to give you an idea of, this is an entire paper, but exposure, vulnerability, and access were the 3 indexes that we used. Each index had different variables to measure that. And one thing that we learned here is that the populations at higher risk, they're not exactly the mobile populations, always. So we always talk about MMPs, and that's been the traditional shortcut to get to this issue. But to be sincere, most of the population has a higher risk of malaria in Cambodia. They're not always mobile. So they are static, but they just lack access of services. So that's something to take into account for programming. So to conclude, targeting populations at higher risk of malaria is a priority. Proven that this underserved group contribute to the spread of drug resistance parasite across 3 borders in 4 countries in the GMS. High population movement, both nationally and regionally, remains a real threat to malaria elimination, especially high movement of migrants, daily workers across the Laotian border, cross-border surveillance. Highest proportion of Plasmodium-positive patients came from Laos. This is our Cambodian experience, but I mean, the introduction and uptake of interventions by populations at higher risk of malaria remains a challenge for a range of reasons, and this is including poor accessibility, social stigma, high mobility, and they live in isolated and do not mesh much with the local villages. So many people talk about border malaria, and I agree, it's border malaria, but the issue doesn't have to do anything with borders, in my opinion. The issue has to do with vulnerability of these populations. Populations who are borders, they have less access, they are much more vulnerable, and they are also involved in activities that they put them at more risk, perhaps. Migrants reported that they travel rather long distances for malaria services, as they live far away from communities or do not know that there is a volunteer in their village. So also access is an issue. So one of the most effective means of health education is interpersonal communication from the village malaria worker. And seriously, what we learned over the last 6 years in Cambodia is that VMWs continue to be the backbone of all implementing interventions. Factors such as dark media zones, limited exposure and access to interventions, and high mobility affect the effectiveness of the strategies and need to be accounted in programming. So I just have a few take-home messages. It's really important that if countries want to target populations at higher risk of malaria, they really need to know their population. If you don't know your population, forget about implementing anything, because you don't know who you are targeting, and you don't know exactly. All countries share different experiences, are engaged in different economic activities, and populations at higher risk are not the same. Mobility is not always the issue. Package your interventions. This is another story, but we also came up with intervention packages for each group. And then measure the effectiveness of your interventions with clear indicators, what really you want to get with that intervention, and is it really cost effective. Cost your interventions, work within the system. Working within the system in Cambodia has worked really well through the established health system, and that way the interventions really are not that costly. Involve the local population, so for example the taxi drivers, the plantation workers, the mobile malaria workers. It's a mobile person, the one who's malaria. Involve the villagers, village malaria workers. Involve the person who are on the scene, who are part of the issue. Don't copy and paste from other countries. You have to do your own needs assessment, what is happening in your country, and I mean, you can learn from other countries, but still, populations at higher risk of malaria are unique within their own societies, so they are not always the same. Thank you. And I would like to acknowledge many people, but here are a few people that I was able to write names down, but much more than this. Thank you.
Thank you very much, Sarah. Do you want to stay there in case there's any questions? Do we have any questions? Yep.
Hi, Sarah. Thanks for that presentation. I just have a quick question. On the taxi program, you spoke about lending the nets. I don't understand why.
Yeah.
I don't understand why you wouldn't just give them one.
I don't understand. I know. Yeah, that's a good question. The way the health system works in Cambodia, perhaps Dr. Soiti might be able to answer that question. It's been an issue that we've been struggling with, the entire malaria system, not only myself, all the implementing agencies, is that in order for you to receive health services, you have to be registered. And I'm talking about internal migration, so if I'm not in the place of birth, I don't have access. So I don't have access to net distribution either, because I'm not a registered person in the village. I don't belong to that village. My village is somewhere in the, I don't know, somewhere else. So that's why we have to do what URC is doing, the lending scheme. So we have to lend nets, insecticide-treated nets, and then once they're done, once they leave the place, they have to give them back to the farm owner, and then it goes back to the new person who comes, and it's like that.
There's do you want to answer? Yeah. Sorry, do you want to answer? Yeah.
Actually, to answer to your question is that, add to what Sarah mentioned, because the internal mobile migrant population are so high, so some are stay very short, a couple of weeks in the area. So respond to the need of net is not enough, because the people just come in and go. So the national program also strategy to distribute the net 1 for 3 years. That is the strategy. So we cannot just repeat it, give the net to the people, the same people, because the people move in and out very frequent. In response to that, we work closely with the farm owner, and the farm owner in agreement that for those who come to the place, a malaria endemic area, should have a net use. And when they leave, either they stay short term or long term, but it's very long term, we give them definitely. But it's just we call about 3-month cut-off point. The net have to return, because we need for other people when they come to work in the place.
Yep.
Wonderful talk. Thank you. I'm very interested in the mass media campaign that you talked about. You said it didn't work very well. Can you elaborate on it a little bit? And
yes.
Also, I have a quick question. Have you tried any other, method to reach out? Is there like any significant cell phone use among the workers? And other thing is the employers of plantations or whatever industries that the people are, working in. I mean, I'm just kind of thinking aloud. So, thank you.
Thank you. No, yeah, that's a very valid question. Actually, mass media, there were different issues. That's why we really need to know the populations before implementing. And that was also due to the times that the message was broadcasted and the times that the migrants usually listen to the radio or watch TV. So that was one of the reasons. The second reason was the dark media zones. There is lack of electricity or access to, to power?
You're doing fine.
In these remote areas. So we call it dark media zones. So they are just dark zones. It's not possible to reach.
The media that you're using are the local media.
Yeah, Cambodian media. But electricity, I mean, is an issue in Cambodia.
Here is I'm familiar with Myanmar. People use battery run the low transmitter radio.
Mm-hmm.
That's actually shortwave, on the lines that people use. And so I'm just curious, what kind of mass media that you use and how it is unsuccessful or
Yeah. We actually did try like mobile broadcasting units, and these use those kind of things, and listener viewer clubs, but the attendance was not that high because farmers are very busy, and when they go back home it's already too late, and then do it at nighttime is already a risk factor for malaria. So, sorry.
Okay, thank you very much. Thank you very much, Sarah.